Let's talk about acute pancreatitis. It's a condition that can pop up out of nowhere. And, while a lot of cases are on the milder side, it has the potential to get incredibly severe, even life-threatening. So today, we're going to break down this really complex clinical challenge from what happens at a cellular level all the way to the critical steps for long-term prevention. Let's start with the organ right in the middle of the storm.
Okay, so at the center of all this is the pancreas. It's this powerful organ kind of tucked away behind the stomach. Think of it like a dual function factory. On one hand, it's making hormones like insulin to control your blood sugar, and on the other, it's churning out these incredibly potent digestive enzymes. Now, normally, those enzymes are supposed to activate in the small intestine to help you break down food. But what happens when that switch gets flipped way too early, right there inside the pancreas itself? Well, that can set off a catastrophic chain reaction.
So let's paint a picture. This is a classic case you'd see walking into any emergency room. A 45-year-old man shows up with this sudden, severe pain in his abdomen. And it's not just any pain. It feels like it's boring a hole straight through to his back. It's constant, it's intense, and it's a huge red flag that something is seriously wrong inside. We're going to follow his journey to really understand how to diagnose and manage this thing.
Right, so to really get what's causing our patient's crazy pain, we've got to zoom in. I mean, way in. What is actually going on at a cellular level that makes an organ turn on itself?
And here's the core idea. It's a super fast inflammation that's all because these digestive enzymes activate way too soon. The key word here, the one you really need to remember, is autodigestion. The pancreas literally starts to digest itself. Yeah, it's like a demolition crew setting off the explosives inside their own headquarters. And the fallout? Well, it can be absolutely catastrophic. So how does this all go down? Think of it like that biochemical factory having a total containment breach. First, something comes along and injures the factory workers, the acinar cells. Could be a gallstone blocking a duct, or maybe too much alcohol. This injury basically hits a panic button, activating all those powerful digestive enzymes when they're not supposed to. Then, those enzymes just go on a rampage, digesting the factory itself and triggering this massive inflammatory alarm that can spread through the whole body, leading to tissue death and even causing other organs to fail. Okay, so our patient is in a world of hurt, and the clock is absolutely ticking. We need a diagnosis, and we need it fast and right. Luckily, there's a pretty simple but super powerful rule clinicians follow. So here's the deal, and what I love about this is how straightforward the diagnostic rule is. You don't actually need all three of these things, you just need two. First, does the story fit? For our 45-year-old, that pain is classic, check. Second, what do the labs say? Are his pancreatic enzymes, especially lipase, cranked up to at least 3 times the normal limit? And third, is there proof on an image? And that's the real genius of this rule. It's all about efficiency. If the story and the labs line up, you've got your diagnosis and you can start treatment right away without even waiting for a scan. All right, when it comes to the lab work, this is a really key point. Lipase versus amylase. And honestly, lipase is the clear winner here, hands down. Why? Because it's way more specific to the pancreas, it shows up earlier in the attack, and it stays high for longer, which gives you a much bigger window to catch the diagnosis. Amylase, on the other hand, can be elevated for all sorts of other reasons, which can really just confuse the picture. Okay, so this naturally leads to a pretty common question. If we have the patient's story and the lab work, do we really need to get a CT scan on everybody just to make the diagnosis? And the answer is a big, clear no. This is a super important takeaway. If you've got those first two criteria locked in, the story and the labs, you don't need a CT scan just to confirm the diagnosis. That saves time, money, and saves the patient from unnecessary radiation. We save imaging for very specific situations. So when do we pull the trigger on a big scan like a CT or an MRI? Well, it's for a few specific reasons. Maybe the diagnosis is still a bit murky. Or, and this is a big one, if the patient just isn't getting any better after 2 or 3 days. That's when we need to start looking for serious complications, like dead tissue, necrosis, or fluid collections. But there is one scan pretty much every patient is going to get, a basic abdominal ultrasound. And that's not to diagnose the pancreatitis itself, but to hunt for the number one culprit, gallstones. Okay, diagnosis is locked in for our patient. Now the focus pivots immediately. What are the first, most critical things we need to do to manage this? The priorities are actually pretty straightforward, and it's all about supportive care. First up, and this is the big one, fluids, fluids, and more fluids. That massive inflammation makes blood vessels leaky, so we have to give a lot of IV fluids to keep the blood pressure up and make sure organs like the kidneys are getting enough blood flow. Next, pain control. This is an intensely painful condition. And finally, nutrition. You know, the old school way of thinking was, don't let them eat or drink anything. We now know that's not the best approach. If they're not nauseous and they can eat, we want to feed them. This is a really critical point about those fluids. More is not always better. It's not about just flooding the patient with as much fluid as possible. The goal is to be goal-directed, meaning we give them exactly what they need based on how they're doing, their vital signs, their lab work. Giving too much fluid can actually cause more problems, like fluid in the lungs. So it's about being smart, not just aggressive.
All right, here's another one of those classic clinical questions. We know that some of that pancreatic tissue can die off. We call it necrosis. And that dead tissue can get infected, which is really, really bad. So it makes you wonder, should we just give antibiotics to everyone with necrosis to stop that infection before it even starts?
And again, the evidence is pretty clear on this one. Nope, we don't do that. Giving antibiotics just in case when there's no infection, it just doesn't work, and it's a great way to create antibiotic-resistant superbugs. We save the big gun antibiotics for when we have proof, or at least a very strong suspicion, that there's an actual infection brewing. So a really important thing to understand is that not all pancreatitis is the same. Far from it. One of the most important jobs a clinician has is to figure out who has a mild case and will be going home in a few days, and who is teetering on the edge of life-threatening organ failure. So how do we tell them apart? So this table shows us how we do it. It's called the Revised Atlanta Classification. Mild is easy. No organ failure, no complications. But the real game changer, the thing that separates moderately severe from severe, is organ failure. And specifically, if that organ failure, we're talking kidneys, lungs, heart, if it lasts for more than 48 hours, that is the definition of severe acute pancreatitis. And at that point, the patient's risk of dying goes way, way up. When we look at imaging, we also see two really different types. On the left, you've got what's called interstitial pancreatitis. See how the whole pancreas is just kind of swollen and puffy? The tissue itself still looks okay, it's just inflamed. Now, contrast that with the scan on the right. You see those dark, splotchy areas that aren't lighting up with the contrast dye? That's necrotizing pancreatitis. That means parts of the organ have actually died. And that is a much, much more dangerous situation. And sometimes you don't even need a scan. The most ominous signs can show up right on the patient's skin. This deep bruising you see around the belly button, that's Cullen's sign. And the bruising on the sides or flanks, that's Gray-Turner's sign, are caused by bleeding from a really badly damaged necrotic pancreas. You don't see these often, but when you do, it's a very, very bad sign. Okay, so let's say our 45-year-old patient makes it through and recovers. That's great news, but the journey isn't actually over. The focus now completely shifts to one thing: making sure this never, ever happens again. And prevention is all about tackling the root cause head on. If it was gallstones that set this whole thing off, that gallbladder has got to come out, usually during the same hospital stay. If alcohol was the trigger, then complete abstinence is absolutely crucial. And if the cause was crazy high triglyceride levels, then you have to be aggressive with diet, exercise, and medicine to get those numbers down. But even if you get the cause sorted out, a single attack can leave behind permanent damage. And this number right here, it's honestly shocking. A full 40% of patients end up developing prediabetes or even full-blown diabetes after just one episode of acute pancreatitis. The inflammation can essentially burn out the insulin-producing cells, permanently damaging the part of the factory that manages blood sugar. And that really brings us to the big takeaway here. An attack of acute pancreatitis isn't just a bad week in the hospital. For many people, it's the start of a lifelong path of chronic pain, problems digesting food, and diabetes. Which really leaves us with a critical question to think about. Knowing just how devastating the long-term consequences can be, are we really doing enough to address the root causes, like gallstones and alcohol misuse, to stop that first attack from ever happening in the first place?